Welcome, everyone. Thanks for joining into our COVID-19 experience in solid organ transplant recipients, vaccine and vaccine guidance. I know you guys have been up to years hearing about vaccines, but you are really in for a treat today as we have three distinguished speakers, Dr. Marinelli, Dr. Rotstein, and Dr. Kumar. Dr. Marinelli is going to start the experience in solid organ transplant, followed by Dr. Rotstein, who is going to review the data on vaccine. And in the end, Dr. Kumar will discuss the vaccine guidance, both for immunocompromised host as well as others. So thank you very much for all three of you doing this. I know everyone has been busy, but taking time out and doing this is really helpful. Of another note, this presentation is being recorded, so if someone wants to access afterwards, they can contact Anna. Tina, please.
Excellent, thank you. So I guess we're only a couple of weeks away from 12 months of having our first COVID positive transplant patients. So really what we're doing is reviewing our first 12 months experience with COVID at our centre and going through some of the things that we found. So here are our conflicts of interest. And so I'll start off, we've been doing a prospective collection of data on our patients with COVID at Toronto General Hospital. Just as a very quick basic overview, I know that we hear this all the time. Obviously, SARS-CoV-2 is the virus causing the disease COVID-19. It's a novel beta coronavirus. The origin of it really is still debated, possibly animal origin with or without an intermediate host. None of this has really been proven. The issue with SARS-CoV-2 is that it has a relatively long incubation period, and it's believed people can spread the disease during that time. So the median is 5.1, but up to 14 days incubation, and that's why part of the reason it's become such an issue. There really is a wide spectrum of clinical disease, and it's really a multi-system disease. It's not just a respiratory disease. This is a nice infographic just demonstrating that there's an asymptomatic incubation period. 80% of people have mild disease, nothing more than sort of a common cold type thing. A lot of these people do actually have abnormalities on their imaging. Severe disease happens in 14% and critical disease and death in less than 5%. And we know that certain things increase the risk factor for severe disease and death, in particular age and comorbidities. There have been a lot of studies in the transplant population. Many of them are case series, case reports, but I just thought I'd highlight two of the bigger or more useful publications so far. So there was a systematic review and meta-analysis in October of all studies. Close to 3,000 solid organ transplant recipients included. Most were kidney, as we'd expect. They had hospital admission rates of 80%, ICU of 30%, mechanical ventilation of 25%, and an 18.6% mortality. There was then a large study, multi-centre prospective cohort study from transplant centres in the United States of 482 transplant recipients, again, mostly kidney, and they had very similar findings in terms of their hospital admissions, mortality. And this group were able to look at risk factors for severe disease, and they found that age and having more than 2 comorbidities were risk factors for severe disease. So just looking at our transplant population, where are they getting COVID? So we assess patients quite thoroughly, and all patients are assessed by one of the transplant ID physicians. So there's a known source of contact in about 60% of cases. And as you can see here in the blue, that most of these cases are acquired from the household. And unfortunately, we see a lot of the times our transplant patients are isolating themselves, but it's family members or friends who are having to go out of the house to work or other things that are then bringing it home to them. We've unfortunately had a few cases of nosocomial acquisition, 9 cases, that's both within UHN and outside of UHN, 1 from a long-term care facility, a few occupational exposures, and a few social gatherings. And really we can see this is the number of cases that we've had, just cases by month at Toronto General in the solid organs only. And we compare that to the epidemic curve in Ontario, and you can see we're just mirroring the epidemic that's happening around us. We are potentially seeing a little bit of a flattening off of our curve down here. It probably by the end of January will end up a little bit flatter than it is here, but there is some indication that things are slowing down. And again, that mirrors what's happening in Ontario. So as of Monday, we'd had 122 confirmed cases of COVID. We've now had 125. The median age is 58 years. Most of them are quite far post-transplant. 5.7 years is the average, and 68% are male. Again, in our group, it really reflects our transplant population that half of our recipients are kidney recipients. We've had 30 cases in liver, 17 in lung, 7 in each of heart and kidney pancreas, and 1 heart lung. We've looked very closely at race because that certainly has been associated with more severe disease, and we've found approximately half of our population is white or Caucasian, about a quarter Indian, and small amounts Asian, Black, and Hispanic. The clinical presentation is quite varied, and to be honest, it's very difficult to capture this information accurately because a lot of patients do actually present in extremis, and when someone's in respiratory failure, critically ill, it's very difficult to actually tease out what their initial symptoms were. So we did look at the symptoms, and it's not surprising that things like dyspnea and gastrointestinal symptoms are much more common and in our hospitalized patients versus the non-hospitalized patients who tend to have more of the classic respiratory tract symptoms. Myalgias, cough, sore throat, anosmia and hypogeusia are typically seen in the non-hospitalized patients. But as I said, we sort of don't have a robust system to track symptoms day by day to really see the evolution. And of note, we have actually had a number of patients who've been completely asymptomatic of COVID who were tested as a part of contact tracing. Looking at our patients, there were 71 patients, so 58% of our group required hospitalisation, of which 42 have been admitted to Toronto General. The average duration of stay is 16.5 days, with a range of 1 day to 83 days. Of the whole cohort, 39% require oxygen, so more than half that are admitted to hospital. 17 have required intensive care admission, of which 13 of them required invasive mechanical ventilation, and we've had 2 patients who required ECMO. One of those patients survived and was discharged on day 83 and went to rehab. The other one unfortunately passed away. We looked at risk factors for hospitalisation, and we chose this as an outcome really because this is a multi-system disease. Just looking at mechanical ventilation is not a good indication of this disease as a whole. So on univariate analysis, we found that those who are older age, had greater than 2 comorbidities, were on baseline prednisolone or mycophenolate, or had a lung transplant, were more likely to be hospitalised. We did see an increased incidence of hospitalisation in the Black race, but this wasn't significant. We're really interested, particularly in this immunosuppression finding, as to how that would play out in a multivariate analysis. And again, on multivariate analysis, looking at some of these factors, baseline prednisolone use was associated with an increased risk of hospitalisation. This is quite an interesting finding, and this shows that it's independent of the transplant type. And when we reflect on something like the recovery study, which is the study with dexamethasone, patients who were given steroids early in their course of illness did worse. So we're seeing a signal here that being on steroids when you acquire COVID and the virus is in its replicating phase may be worse, may portend worse outcomes. Again, on multivariate analysis, we found that having more than 2 comorbidities was associated with increased risk of hospitalisation. And this is similar to the other large study in CID. Most patients have their immunosuppression reduced, so 2/3. Very early on in the piece, when we were still learning about COVID, the CNI was often reduced, but that's very rarely done now. More commonly now, we reduce the antiproliferative, and the mean reduction is 76%. A lot of patients, when they're critically ill, it's stopped. Others who are managed in the community, we often reduce it by 50%. Remdesivir wasn't really available to us until October, and since that time, almost every patient who's been hospitalised has had remdesivir, and most have also received dexamethasone therapy. And just important to note that we do wait until the disease has progressed before we give dexamethasone. 1 patient has had convalescent plasma, and 1 patient had tocilizumab. Looking at our infectious complications, mainly the hospitalised group have had imaging done. The not hospitalised group mostly didn't, but 40% of our patients, most patients who were hospitalized had radiographic evidence of pneumonitis. And it's often very difficult in these patients to tell viral pneumonia versus bacterial pneumonia, and it's very common for our patients to be treated for bacterial pneumonia. So 40% of patients received antibiotics, and of our entire cohort of 122, a bacterial etiology was only proven in 3. We've been watching very closely for other complications. We've had 1 patient who reactivated herpes zoster while they had COVID, 5 CMV viremias, 7 bloodstream infections, 1 Clostridium difficile colitis, and 1 patient who had invasive pulmonary aspergillosis, which is something that we're watching out quite closely for because there is some emerging evidence about aspergillosis in patients with COVID. Looking at allograft rejection, we've had no episodes of allograft rejection within 30 days of COVID-19 symptom onset. Most patients are still relatively soon post their COVID disease, and so we haven't completed a lot of follow-up for them, but we did note that there have been 3 cases of allograft rejection more than 30 days post-COVID. There was 1 episode of rejection in a pancreas allograft at day 40, and this was attributed to a reduction in immunosuppression. There was a case of grade 2/1R cardiac allograft rejection at almost day 50, and T-cell mediated renal allograft rejection at day 82. And this is certainly something we will look at closer going forward to see about the association of COVID-19 with rejection. Looking at our mortality, our overall mortality rate as it stands is 13.9%, and the average time from COVID-19 to diagnosis to death is 17.6 days. Keeping in mind that we may diagnose people quite late into their illness. Most of the deaths we've seen, or the highest rate of death, has been in the lung transplant population, which we've had 7 patients pass away, of which 5 of these patients had chronic lung allograft dysfunction. 1 had a bowel perforation, and 1 was, I think, almost 18 years post-transplant and elected for palliation rather than active management. There's been 1 cardiac transplant patient who died, 6 renal transplant patients, 3 livers, and we've had no deaths in kidney pancreas transplant. In most of the cases, death has been attributed to COVID-19 hypoxic respiratory failure or sepsis. As mentioned, there's 1 patient with a bowel perforation, possibly contributed to by high-dose steroids, and there was 1 patient with an intracerebral bleed at about day 43, which again, likely related to COVID and the critical illness and coagulopathy and inflammation associated with that. Now I'm going to talk a little bit more about some of the laboratory work and immunologic work that we've done, just with the preface that none of this is actually my work. Dr. Kumar and Dr. Humar's team in the lab, and particularly Dr. Victor Ferreira, have been working very hard on this and done some very skillful work. It's very interesting. So we looked at viral loads and duration of shedding in a subset of patients, and we did this by inviting people to submit serial nasal swabs. In hospitalised patients, this was quite easy to do, and in outpatients, we sent the swabs to them and they were self-collected swabs. So it was a fluorogenic probe-based time PCR. Viral RNA was extracted from the swabs. We had 25 patients in total for a total of 120 swabs that we assessed. The median time from symptom onset to the first swab was 8 days. We found that 76% of patients had a detectable SARS-CoV-2, and the median duration of shedding was 10 days. We looked at the shedding, and there were a few patients who actually did shed for less than 14 days, and these were all kidney or liver transplant recipients with very mild disease. 1 patient continued to shed until day 30, which was the day of death for that patient. And we didn't find any significant association between hospitalisation and duration of shedding. Looking at the SARS-CoV-2 structure, there's lots of, and I've just put up this picture so we can talk more about the antibody responses, looking at the different proteins associated with it, particularly the spike protein, membrane protein, and nuclear capsid. So we looked at antibody responses in transplant recipients using 2 different commercial assays against anti-S and anti-NP, so anti-spike and anti-nuclear protein antibodies in 26 of our solid organ transplant recipients. And we can see here the change over time. This is the anti-S antibody levels and the anti-NP antibody levels. Of those who had a blood test done, we had 13 patients who were tested less than 14 days before symptom onset. After symptom onset, 20 and 30% of patients had positive antibodies. When we looked at those who had tests done greater than 14 days, this increased up to 90 and 85% were positive. We found that generally the antibody response increased over time, which is what we would expect, and it persisted, although we haven't tested right out to sort of a longer duration. There were 3 patients that had no anti-NP response, and two of these patients also had no anti-S response. All of these were liver and kidney transplant recipients with mild infection who didn't receive any antiviral immunomodulatory therapy, but there wasn't really a lot more that we could tease out about these patients. We found that the anti-S and anti-NP antibodies were highly correlated and they didn't vary according to disease severity. We were able to compare these responses to a group of non-transplant controls. So we had 15 non-transplant controls who had serum collected greater than 14 days post-symptom onset, and there really was no difference in the antibody response. Victor looked at T-cell responses as well. So the PBMCs were collected during convalescent phase in transplant recipients. So we had 20 transplant recipients and again the 15 non-transplant controls who had a history of COVID. They were stimulated with overlapping peptide pools of spike, membrane and nuclear protein. And he looked for exhaustion markers, particularly CTLA4, PD-1, TIM, and SARS-specific cytokines being interleukin-2, tumor necrosis factor, and interferon gamma. So he looked at the proportion of T cells expressing the exhaustion markers, as mentioned, and they found that transplant recipients had a high frequency of PD-1 expression with a lower expression of TIM3 and CTLA4. And they found that hospitalization wasn't associated with total of CD4 or CD8 T cell frequencies, but it was associated with PD-1 expression. And this sort of indicates that that T cell exhaustion may be a marker of more severe disease. He looked at the frequency of SARS-CoV-2 specific T cells in transplant recipients and measured them after stimulation with the SARS-CoV-2 spike nuclear protein and membrane protein. So this graph here shows the total number of SARS-CoV-2 reactive cells that produced any cytokine, so TNF, IL-2 and interferon, in response to being stimulated with these peptide pools. So the y-axis shows the individual patients. And we can see that both in the CD4 and the CD8 compartments, transplant patients have a robust response to all 3 peptide pools, especially the spike protein. On the charts on the side here, we can see that in the CD4 compartment, most patients produced all 3 cytokines. And overall, again, this shows a very robust response to SARS-CoV-2 in transplant patients who've recovered from COVID-19. Obviously, the patients who didn't recover, we weren't able to test for. So from our study and the work that we've done so far, we can see that the number of comorbidities and prednisolone use are associated with severe disease. The mean duration of viral positivity was 17 days from symptom onset. The humoral responses to anti-S and anti-P antibodies form in most transplant patients by 2 weeks and persist up to 60 days, which is the limit of our testing. SARS-CoV-2 specific CD4 and CD8 T cell responses form in the majority of transplant patients, and cellular and humoral responses were comparable to non-transplant controls, but there was evidence of T cell exhaustion phenotype in transplant patients, particularly those that were hospitalized. So I just wanted to acknowledge there's a number of people that have contributed to this data and to this study so far. As I mentioned, Victor Ferreira and his team from the Kumar lab, and a number of people have helped us to get samples and do lots of testing. The whole Transplant ID team who's been involved, particularly thanking Dr. Kumar for allowing me to be involved in this study, and the rest of the team, as I mentioned, we all review all of these patients and for both clinical purposes and also for collecting data. And I really also wanted to thank basically the entire transplant team. It's not, we've made a concerted effort to capture all transplant patients with COVID-19, which means that we do need to know about outpatients, inpatients, those admitted to other hospitals. And we really wouldn't have been able to do this without excellent lines of communication with the transplant coordinators and the transplant teams. So I would really like to thank you all for your help and assistance with this. So we might leave questions to the end. I'll hand over to Dr. Rotstein, who's going to talk about vaccines.
Thank you very much, Tina. Thank you for putting up this slide. I'm going to be talking to you about COVID-19 vaccines, and I want to orient you to this first slide. Down in the right-hand corner, you'll see the type of vaccine. That is the platform for the vaccine that we use. So we're going to be talking about protein vaccines, that's recombinant protein vaccines, virus-like particles, vector-based vaccines, and those use adenovirus as the vector to transmit genetic material about the spike protein, messenger RNA vaccines, which you're quite familiar with now, based on the Moderna, as well as the Pfizer BioNTech vaccine. DNA vaccines, those are plasmids that encode the spike protein genetic components. And finally, inactivated vaccines, where they've taken a coronavirus and inactivated it and then made it into a vaccine. So now go to the left side of this slide. Ooh, please go back. And you'll see that Canada has agreements with various companies, such as Sanofi GSK and Novavax. These two companies are producing protein-based vaccines, that is recombinant vaccines. Medicago has a virus-like particle. Johnson & Johnson uses an adenovirus vector, as does AstraZeneca. Moderna and biotech are the messenger RNA vaccines. And on the bottom, you'll see the inactivated vaccines. Of these vaccines, licensure has really only occurred with a small number of the vaccines. So you'll see that AstraZeneca has been licensed, Moderna and Pfizer, both licensed, and on the bottom, Sinopharm and Covaxin. Could I have the next slide, please? Thank you. I want to orient you to the next series of slides. On the far left, you'll see the company that is producing the vaccine. The next column will be the platform that they're using. And then you'll see the supply commitment that Canada has made with the company. You will then see in the fourth column where they are at with regard to phase 1, phase 2, and phase 3. Then you'll see some results of various studies. And in the case of Novavax, we only have phase 1, phase 2 data. This vaccine will be administered in 2 doses, 21 days apart. It has not been approved, but it is a novel vaccine because what they have done is they've created a recombinant full-length spike protein and then mixed it with an adjuvant. Next slide, please. Sanofi GSK is really in its infancy. Once again, they're using recombinant technology, and we have no data at all. But Canada has an agreement of 72 million doses. In the former slide, I should have mentioned that Canada has an agreement with Novavax for 72 million doses as well. So I don't know who did the intel, that is the intelligence gathering for the federal government, but as you'll see as we go through these, that we only have an agreement with Pfizer for a total of 10 million courses. That's why we have a shortage right now. Why we have an agreement with Sanofi GSK for 72 million doses, I do not know, but we do. Medicago is an interesting vaccine. This vaccine is created in Quebec, and it's a virus-like particle. So what they do is they distill the virus so that it's non-infective, and they then infuse the virus into a plant. It's the Nicotiana plant, and then the virus grows in the plant. Then what they do is they chop up the leaves once the leaves are mature, and they make a vaccine out of the leaves and combine that with an adjuvant, and they use the AS03 adjuvant. Yes, Canada has an agreement with Medicago. This vaccine is progressing. It is now in phase 3 in the United States. It will be given as 2 doses, and that's in the second last column on the right. And it is quite stable because you can store it at 2 degrees Celsius. The last vaccine on this slide is the Variation Biotechnologies vaccine. It's made in Ontario. Forget about it because it's really not moving forward. Next slide, please. Now, the Sanofi GSK vaccine is once again, could you go back, please? One slide back. One more. Thank you. Oh, no. Well, at any rate, I'm just going to go on from here. Good. If you could go back just one slide.
Sorry. This
Okay.
slide?
Yeah. So I mentioned that the Variation Biotechnologies is not really going anywhere, so we can really forget about it. It's made in Ontario. Next slide, please. Thank you. Okay, the AstraZeneca vaccine you've heard a lot about. It is an adenovirus vehicle with genetic material for the spike protein in it. And there is an agreement with Canada, but it's only for a total of 20 million doses. Now, this vaccine has produced phase 2 and phase 3 data, as you'll notice here in the middle of the slide, recently published in Lancet in 2021. The problem with it is that the vaccine works very well in young people, but in people over the age of 55, the efficacy is only 70%. In young people, it's 90%, and that's a bit of a problem. It is very stable and can be stored at 2 to 8 degrees Celsius for 6 months, and 2 doses are administered 29 days apart. This vaccine is approved both in the UK and India. India has created its own variation on the vaccine, but they use the AstraZeneca vehicles. Next slide, please. Now, I'm going to talk about the Russian vaccine, Sputnik 5. This is a unique vaccine. I cannot believe how they created this, but they did. Essentially, they used 2 adenovirus vehicles. One dose, the first dose, is with the adenovirus 26, and the second dose is with the adenovirus 5. Some preliminary data have been produced, and the phase 1, phase 2 data were published in Lancet in 2020. 2 doses are given 21 days apart, but we have not seen the phase 3 data. And this vaccine has already been approved in Russia, and they are administering it in Russia. Next slide, please. CanSino is an interesting vaccine. This vaccine is produced in China. It's an adenovirus vehicle. Some data have been produced in phase 1 and phase 2. In Canada, we were supposed to undertake clinical trials with the vaccine. However, it was embargoed by China because of the Huawei fiasco that occurred. And as you know, because of that, we are not able to do any clinical trials with the vaccine. The vaccine currently is in clinical trials in Argentina, Chile, Mexico, Pakistan, and Russia. Next slide, please. Now, the J&J vaccine is also interesting. It's an adenovirus-based vaccine. So SARS-CoV-2 genetic material for the spike protein is located within an adenovirus vehicle. Now, These adenoviruses that are being used, I would tell you, are non-replicating adenoviruses. However, there is an issue with the adenoviruses in that they may be immunogenic in patients. That has been demonstrated with the AstraZeneca vaccine. This vaccine is quite potent. There's talk of just giving one dose because you'll see in the column that illustrates the results, it was 100% seroconversion after the second dose, but very good results after one dose only. The 2 doses are administered on day 1 and day 57. It can be stored for a prolonged period of time at 2 to 8 degrees Celsius. And this vaccine is advancing and will be considered shortly by Health Canada. Next slide, please. The BioNTech Pfizer vaccine, you know about, it's a messenger RNA vaccine. I'm going to be talking about this more in a moment. It has 95% efficacy, as noted in the column about the results. It's administered in 2 doses, 3 weeks apart. The only problem with it is it has to be stored at very low temperatures. Could I have the next slide, please? Now, the Moderna vaccine, once again, is a messenger RNA vaccine. So basically, the messenger RNA has the genetic code for the SARS spike protein, and it's located in a lipid nanoparticle. The data has now been published, the phase 3 data, published by Lindsay Baden and colleagues in New England Journal of Medicine, December 30th, 2020. And as you'll notice in the column about the results, it's 94.1% effective. The vaccine is administered in 2 doses, day 1, and then another vaccine 28 days later. Next slide, please. Now, there are 2 inactivated vaccines. Basically, what has happened with these vaccines is that they've inactivated the SARS-CoV-2 virus and then mixed it with an aluminum adjuvant in the case of Sinopharm. This is produced in China. And this vaccine has been approved in the UAE, and they're administering it in the UAE and in China. It's reported to be 86% effective in the data that we've gotten from the UAE and 79% effective in the data from China. Now, Covaxin is an inactivated COVID-19 vaccine. Essentially, they've taken SARS-CoV-2, inactivated it with beta propoliactone, and combined it with an adjuvant. This vaccine is approved in India, and it's 60 to 70% effective. Next slide, please. I now want to just talk briefly about the efficacy of the mRNA vaccines because that's pertinent to us now. So the way the mRNA vaccines work is it's messenger RNA that encodes for the spike protein, and it's contained within a lipid nanoparticle. There are 4 lipids in the nanoparticle. The lipid nanoparticle basically transmit the mRNA to the cell, and you can see in this slide that the mRNA enters the cell. It then goes to the ribosome. The ribosome produces a spike protein. It's handled by the Golgi apparatus and processed, and then that spike protein goes on the surface of the cell, and then the body recognizes this as foreign and then produces antibodies. And that's how we get our elevated IgG antibody levels. Next slide, please. Now, let's look specifically at the Pfizer-BioNTech vaccine and the randomized clinical trial. You'll notice in the top part of this slide, there's an inset that shows you the 2 curves, both for the placebo in blue and the Pfizer vaccine in red. You'll see that the 2 lines, the 2 curves, are superimposable up to day 12. Well, starting at day 12 to 14, which we know that's when IgG is produced, the curves diverge. So if you look at the data say that after dose 1 up until dose 2, the vaccine is 52.4% effective. That's in the little red box on the bottom. Then 7 days or greater after the second dose, the efficacy of the vaccine rises to about 95%. Next slide, please. However, we have to look at the data a little more closely. After the first dose to before the second dose, the vaccine efficacy is 52.4%. So that's after you give the first dose to the second dose. However, starting 14 days after the first dose to the second dose, the efficacy is really 92.3%. That's very significant. So once IgG starts to be produced at day 14, until the time you give the second dose, the efficacy is 92.3%. Now, you give the second dose, and greater than 7 days after the second dose, the efficacy rises to about 94.8%. Next slide, please. Now, here's the Moderna vaccine, and you can see with the Moderna vaccine, you get it at day 0, then you get your second dose at day 29, 28 days later, and you see once again that the curves start to diverge at a certain point. Could I have the next slide, please? Well, let's look more closely at this. So after the first dose, and only 1 dose is given in some patients, that's what the data shows, the efficacy was 80.2%. From 14 days after the first dose, that's when IgG starts to be produced. The efficacy rises considerably, and it's 92.3%. Overall, after 2 doses, the efficacy is 94.1% in the per protocol analysis. Next slide, please. Now, there are some issues with the COVID-19 vaccines that I just want to go over quickly. Next slide, please. How long does the antibody persist for after you give the vaccine? This concept is called durability of antibody response. Now, with the Moderna, that is the mRNA 1273, it produces antibody after the 2 doses are given, and you'll see that in this figure. So you get your first dose, and then you get your second dose 28 days later. There is persistence of antibody for 129 days. That's what we know at this time. Now, it's irrespective of the age of the recipient. So whether you're 18 to 55 years of age, or 55 to 70, or greater than or equal to 71 years of age, the efficacy of the vaccine is there, and there is durability of the antibody response. You would think that someone who's, let's say, over the age of 71, there may be senescence and there's loss of the antibody. Yes, there is a slight loss of the antibody, but it's not great. With the Pfizer-BioNTech vaccine, the durability of antibody response is only until 28 days after the second dose. That's all the data that we have right now. So that's around day 52 or so. Next slide, please. Now, is there anaphylaxis related to these vaccines? Yes, there is, and it's believed to be related to the polyethylene glycol. The incidence of this with the Pfizer-BioNTech vaccine is 11.1 cases per 1 million doses administered. With the Moderna vaccine, the incidence is only 2.5 cases per 1 million doses administered. Next slide, please. Finally, a key question that you're asking yourself is, Do the vaccines work against the SARS-CoV-2 variants? Well, the Pfizer-BioNTech vaccine has been looked at in human serum. So they've given the vaccine, then they've checked human serum for neutralizing activity against B117. That's the UK variant. And there was neutralizing antibody. Both Pfizer and Moderna have been looked at with other SARS-CoV-2 variants, and there is reduced activity, that is reduced neutralizing activity, which is not good. We may have to revamp some of these vaccines in the future to ensure that we're covering for these variants. Finally, Moderna vaccine has been looked at in 8 participants who received 2 doses, and they checked for neutralizing antibody against the UK B117 variant, and it was good, but it was reduced against a South African B1351 variant. So with that, I'd like to stop and turn it over to Deepali to finish off. Thank you.
Thanks, Coleman. So I'm going to talk about vaccine recommendations for our patients. Tina has very nicely outlined the severity of disease in our patients, and Dr. Rotstein has gone through the different vaccines available. The first thing to know is that there are really no data on these vaccines in transplant recipients, and that's because immunocompromised populations were excluded from the phase 3 trials. And they'll probably continue to be excluded from the future phase 3 trials as well. The only phase 3 trial that I have seen where transplant patients may be included would be the Johnson & Johnson vaccine trial. But it's difficult to know how many patients they'll actually include in that trial. So after consideration of benefits and risks, the various transplant societies around the world have recommended that our transplant patients receive the available vaccines. And that includes the American Society of Transplantation, the Canadian Society of Transplantation, the British, the ISHLT, as well as the TTS. As well, in Canada, the NACI group, the National Advisory Committee on Immunization, has actually recommended, has also recommended that we give a complete COVID-19 vaccine series to individuals who are immunosuppressed due to disease or treatment. But what they say as a caveat is that we give it if the risk assessment deems that the benefits outweigh the risks for the individual, and also let the individuals know that there is absence of evidence on the use of vaccine in this population. Next slide. So what is this discussion of risk and benefit that we need to have with our patients? So I've put the potential risks of COVID on the left and the potential unknowns about the vaccine on the right. So basically, the risk of COVID, as you saw in Tina's presentation, really is there is a risk of severe disease in our patients, especially with age, comorbidity, and also a risk of infection, such as with occupation and living conditions. There's also a risk of rejection that may happen with COVID itself, with the manipulation of the immunosuppression that we do when patients have COVID infection. And the fact is that the vaccine has a very high efficacy in these trials. So even if it doesn't have the 94 to 95% efficacy in transplant patients, it's likely to have some partial efficacy. Now, on the other hand, the general efficacy is actually unknown. So there may be a false sense of security in some of our transplant patients. And we also don't know the duration of protection and whether antibody or T cell immunity will wane faster in transplantation. And this is a new type of vaccine platform. It's an mRNA vaccine. We don't have other human vaccines that are mRNA vaccines. So the adverse event profile is largely unknown, and whether there will be off-target effects such as rejection is largely unknown. But I think on balance, the the data that we have balancing those against theoretical considerations, I think balances towards actually vaccinating our transplant patients. Next slide. So having said that, and offering vaccine to our transplant patients, what are some of the timing considerations to make sure that we get the best immune response in our patients? So the CST guidance has a table that I've put on this slide that goes through some of the timing considerations. And I won't go through all of these because there's a lot of detail in this, but I urge you to read this guidance. But some of the highlights are, for example, when possible, we administer the vaccine in the pre-transplant setting, if possible. In post-transplant patients, so if a patient has not received vaccine in the pre-transplant setting, wait at least a month after transplant to provide the vaccine. And this is regardless of whether they get ATG induction versus basiliximab induction. It would be great to wait a little longer. I think if we waited till 3 months, we might get a little bit of a better immune response. But depending on how much, it's a balance in terms of depending on how much COVID is circulating at the time. Other things that are in this guidance, if a patient has had COVID before, wait for 3 months from the initial diagnosis of COVID and symptom recovery before giving the COVID vaccine. It's likely, as you saw from the antibody data, that patients will produce antibodies from having had COVID infection. So it's good to have a wait period before giving the actual vaccine. And then there's some allergy advice that vaccine should not be given to patients that have had a known anaphylactic reaction to a component of the vaccine. And that's actually the, what we know now is that it's the polyethylene glycol component that's probably the likely thing that patients react to. But the bottom line is, since efficacy is expected to be lower than the general population, it's strongly recommended that patients actually continue to practice masking and hand washing as well as physical distancing, and that we vaccinate the household contacts of the transplant recipients, because as you saw in Tina's presentation, even though our transplant patients are isolating, it's their household contacts that are getting sick and bringing COVID home to them. Next slide. So the next thing I want to talk about, now that we've said that transplant patients can be vaccinated, is how do we prioritize our patients? So this is actually the CDC recommendations for vaccine prioritization, just to put things in context. The CDC has recommended that, the CDC has actually divided their prioritization into different phases. So phase 1A is the healthcare workers and long-term care workers, just like we do in Ontario. Phase 1B is non-healthcare essential workers, followed by age over 65. And then in phase 1C is the persons with high-risk medical conditions. And this is actually where, if you look at the list of the high-risk medical conditions, this is where the transplant patients fall. So this is the kind of thing we have to consider. Next slide. So what is the Ministry of Health doing? Well, we know that in phase 1, there is the healthcare workers, just like the CDC. Phase 2 is age 80 plus, decreasing in 5-year increments, other frontline essential workers, but also those with high-risk chronic conditions. So this is where I believe our transplant patients will fall into this category. At this time, we're actually working with the Ministry of Health to sub-prioritize transplant patients within the phase 2 category. Next slide. So, and then the other thing we're doing is we're doing a vaccine study at UHN to try to build the data and try to see what is the immune response in our transplant patients. So, so this is a study of 120 transplant patients compared to 120 non-transplant control healthcare workers. And we're looking at immune responses, including antibody and T cell responses, as well as some safety outcomes. And many of you may be already participating in the study, so I thank you for that. But if you know if anybody wants to participate, there's an email there, preventcovid@uhn.ca. So with that, next slide, Tina. With that, we'll all thank you for your attention and take any questions. I think we have 10 minutes.
Thank you for a very nice presentation. I see that Shaf has raised his hand.
That was a great presentation from all of you. Thank you very much. I have two questions, one for Tina and one for Coleman, I guess. Tina, the data that you showed of prolonged shedding in some patients, is there a way to know whether that's a viable virus or whether it's viral fragments? And because sometimes we need to know that, both for obviously for isolation, but also in patients we're considering transplantation.
I might defer to either Victor or Dr. Kumar to answer that question, if that's okay.
Yeah, I'll answer that, Shaf. So you're right, you're completely right. We don't know if this is just long-standing, viral RNA that we're detecting versus replicative virus. There are some research methods that one can use to distinguish between those two, like looking at subgenomic RNA or looking at something called a negative sense strand RNA. But frankly, it's actually very difficult to do. One way that we have tried to do this in the past is to look at CT values. So CT values are something you get when the PCR is run, and a higher CT value basically means low viral load. So that's one way of doing it. The other way is to look at what gene is being detected in the PCR, so calling the microlab and figuring out which gene is actually being detected. The assay used in the PCR detects 3 genes. So for example, if you're getting 1 gene detected out of 3, it may be sort of non-replicative virus. But I think overall, it's actually very difficult to figure out one way or the other.
And for Coleman, you mentioned the adenovirus itself can be immunogenic, and we've done a lot of work with adenoviral gene therapy, looking at gene modifying organs with IL-10 for transplant and so on. One of the things we found is that the immunosuppression for transplant can actually facilitate the efficacy of adenovirus to produce its transgene protein and blunt the anamnestic response or immune response to the vector itself. So and we have data from that from our own lab comparing animals with cyclosporin, Imuran, and prednisone versus without it, showing that you can get much more prolonged transgene expression with transplant immunosuppression. And you can redose safely without the inflammatory response. So there's really a possibility that the ad vector could work very well in transplant patients, and that might be a study that we could do here, being aware of our previous work.
That's interesting, Shaf. I didn't know that. That's very interesting.
Yeah, they're all our papers because, when ad vectors fell out of favor with cancer and CF because it wasn't practical to use immunosuppression, that's when I had the idea that, well, our patients are already immunosuppressed, so ad vectors could work very well, and we proved that. And my last comment or question is the mRNA that's given with the current vaccines. My understanding is that it's transduced in the muscle cells. Then you have the immune response to the produced protein. Is that your understanding, or did you run into anything that shows what are the effector cells for the vaccine? Is it your deltoid muscle?
No, I didn't identify anything like that, Shaf. That's new knowledge to me. I'm not sure. I can't answer that because I don't know.
Okay.
Maybe someone else can, but I don't know.
Hi, Shaf. This is Victor. It probably has to do with the antigen presenting cells in the tissue. Those likely pick up the spike protein, process it, and then they go on to induce sort of T cell responses, which eventually lead to B cell responses.
But they'd have to be drawn there or something, right, to really be effective. It's hard to imagine that kind of efficacy of 90% from that. But anyway, it's just an interesting thought.
So we have, sorry, but we have two raised hands, one with Atul and then Stephen Jouet. I'm mindful of the time, and so Atul.
Oh, okay, thank you. Yeah, so well, first of all, thank you to all of you. That was great. And Tina, I know you've done a huge amount of work on this, and as well as Victor, so thank you. And Deepali is very modest, but she actually wrote the CST guidelines, so I should just acknowledge that. So my question relates to, I know in Britain, the transplant patients have actually been prioritized, and I believe in a number of European centers. And I wonder, is there any data yet emerging on safety signals in that initial experience in Europe that any of the three of you are aware of?
Can I answer that, Atul? Actually, I asked that question of AstraZeneca myself, and I've not received the response yet. So I don't know. But I did ask that question because I was interested in that. And at the moment, I don't have the response.
Okay, thanks.
In the UK, they are starting a specific study in organ transplant recipients to look at vaccine.
Okay, thanks.
Jouet.
Hi, thanks to everybody. Those were great presentations, and I really learned a lot. I have a question. I guess maybe Victor would be best positioned to answer this about the exhaustion signal that you saw in the T cell response in the transplant patients. I'm wondering if you did intracellular cytokine staining as well to sort of correlate that with a functional phenotype. And I guess the follow-on question from that is, do you worry, or does anybody who presented worry that this might be an early signal that the vaccine may not be as effective in transplant patients?
So we did do parallel ICS testing alongside detection of exhaustion markers. The problem is that the overall frequency or the overall number of antigen-specific cells we found was relatively low. So it kind of prevented us from going further and sub-analyzing. I think that would possibly sort of jeopardize the validity of the data. So we kind of stopped it there. But that's a really good question. And I think it's possible that the increased expression of the exhaustion markers could be offsetting the fact that these transplant recipients are developing T cell responses. They're immune suppressed, and in several studies, they show that transplant patients often have poorer antigen specific responses, but here we're showing that they're sort of on par, but the expression of these exhaustion markers could be jeopardizing their functionality. And that could also extend maybe to the vaccine. And that is something that I think we plan to evaluate in our vaccine study.
Great, thanks.
All right. Thank you, everyone, for active participation and excellent presentation. My kudos to all three of you, Tina, Dr. Rotstein, and Dr. Kumar. In the interest of time, I'll have to close this session, but feel free to reach to them in case of any questions, and have a wonderful day. Thank you.
Thanks.